Welcome to the Deep Dive. Today we're tackling a really important question in vascular health. We're looking long-term at two ways doctors repair something called an abdominal aortic aneurysm, or AAA.
Right. That's the main artery carrying blood from your heart down through your abdomen. And an aneurysm is basically a dangerous bulge, a weakening in that vessel wall.
Exactly. And we've got a deep stack of information here, focusing specifically on the 15-year results from a landmark study, the UK Endovascular Aneurysm Repair Trial 1. People just call it EVAR Trial 1.
That's the one. It was a big undertaking, ran from 1999 to 2004 across 37 UK centers, involved over 1,200 patients, all aged 60 plus.
And they all had these AAAs that were, what, 5.5 centimeters or bigger?
Yeah, that's generally the point where repair is considered necessary. And crucially, these patients were all deemed fit enough for either of the two main options, traditional open surgery or the less invasive technique, endovascular aneurysm repair EVAR. They were randomly assigned.
Okay, so EVAR, that's the one done through smaller incisions, right? Using catheters.
Correct. Less invasive, generally. And initially, it really looked like the clear winner. The first reports from EVAR Trial 1 definitely showed some significant short-term benefits.
What kind of benefits are we talking about?
Well, the most striking was operative mortality. So the risk of dying within 30 days of the actual procedure. For EVAR, it was only 1.7%.
Okay.
Compare that to 4.7% for open surgery. That's quite a difference.
Yeah, definitely.
And even looking out 4 years, there were fewer deaths caused directly by the aneurysm itself if you'd had EVAR. So understandably, there was a lot of initial excitement.
Less invasive, lower immediate risk. It sounds like a no-brainer almost. But, well, medicine's rarely that simple, is it? Things can change over time.
That's precisely it.
Which brings us to the core question for today's deep dive. What did things look like much, much later? 15 years down the line, did that early EVAR advantage actually hold up? Or did the story, shift?
Well, this is where that long-term follow-up becomes absolutely critical. And yes, the 15-year data, it paints a much more nuanced picture. That early survival edge for EVAR, it didn't last.
It didn't. So what happened?
In fact, after about 8 years or so, the trend actually reversed. Open surgical repair started to demonstrate better survival outcomes.
Wow. Okay, so that initial promise faded. What were the actual numbers at 15 years for overall survival?
So looking at total mortality death from any cause, the rate was about 9.3 deaths per 100 person years in the EVAR group.
Okay.
And it was 8.9 per 100 person years in the open repair group. Now, while 8.9 is slightly lower than 9.3, that difference in total mortality wasn't statistically significant.
Meaning it could have just been down to chance.
Exactly. The p-value was 0.14, well above the usual threshold. So for overall death rates, they ended up looking pretty similar in the very long run.
Okay, similar overall death rates. But what about dying from the aneurysm? I mean, that's why they had the surgery in the first place.
Now that is where we see a really important difference. When you isolate the aneurysm-related mortality, things look quite different, especially after that 8-year point.
How different?
The EVAR group had a significantly higher rate of aneurysm-related death after 8 years. The adjusted hazard ratio was 5.82.
Whoa, 5.82. That sounds high. And that was statistically significant.
Oh, yes. Very significant. P-value of 0.00064. So highly unlikely to be chance. Basically, after year 8, the risk of dying from the aneurysm was nearly 6 times higher for patients who'd had EVAR compared to those who'd had open repair.
6 times higher. That's really striking. Why? What was happening in the EVAR group so many years later?
The main culprit was something called secondary aneurysm sac rupture.
Okay, explain that. With EVAR, they place a graft inside the aneurysm, right?
Correct. It relines the aorta, excluding the bulge. But the original aneurysm sac is still there, outside the graft. And sometimes, years later, that sac can still fail and rupture even with the graft in place.
And that happened more often after EVAR.
Much more often in this study. There were 13 deaths from late sac rupture in the EVAR group. That's about 7% of them.
7%. Wow. And in the open repair group?
Only 2 such deaths. About 1%. So a really stark difference in that specific dangerous complication.
That makes a lot of sense.
Yeah.
It explains that higher aneurysm-related death rate. So the initial fix wasn't always permanent, or at least vulnerabilities remained. Was anything else contributing to the difference in survival?
Well, the study also noted an increase in cancer deaths in the EVAR group.
Really? Cancer.
Yes. Though the researchers pointed out this wasn't the primary driver of that big gap in aneurysm-related deaths we just discussed. The sock ruptures were the main story there.
Got it. So these 15-year findings must have really made people sit up and think, especially the experts in the field. What was their take on it all?
Absolutely. The commentary around these results really reflects that initial journey, the hope and excitement for EVAR as this less invasive option, which, as we said, the early data supported. But even by the 10-year point, people were noticing things. While overall deaths might have been leveling out, EVAR seemed to come with more graft-related complications.
Like what?
Things needing fixing, more reinterventions, more procedures down the road to sort out problems with the graft itself, and that, of course, starts to add up in terms of complexity and, frankly, cost over the long haul.
So even before the 15-year data landed, there were hints that the long-term picture for EVAR might involve more hassle, more procedures, maybe more money.
That's right. And what became clearer with the full data was this idea of a sort of cluster of EVAR patients who were at particularly high risk for those late sac ruptures.
Okay, a high-risk group. What characterized them?
Well, often these patients showed the aneurysm sac actually growing year on year, even after the EVAR.
Growing, despite the graft.
Yes. And this was often linked to things called endoleaks. That's where blood is still managing to get into the aneurysm sac outside the graft. There are different types, type I, type 3, sometimes type 2 endoleaks. Also issues like the graft kinking, bending, or even migrating shifting position.
So specific problems you could potentially see on scans.
Potentially, yes. And tragically, if one of these patients did experience a secondary rupture, the outcome was often devastating. Mortality was around 67%.
2/3. That's incredibly high. So identifying those high-risk patients and monitoring them closely seems paramount.
It absolutely does. But here's a major practical problem the experts highlighted: patient follow-up.
Getting people to come back for checks.
Exactly. It's tough. By the time they reached 15 years in this study, only about 10% of the original group were still having the recommended annual checkup with a CT scan.
Only 10%.
10%. People move, they feel fine, life gets in the way. You know how it is. But the consequence is that potentially dangerous sac growth could be missed.
That's a massive gap. If the people most at risk aren't getting checked, well, like you said, it's a ticking time bomb, isn't it?
That really is the crux of it. The 15-year results forcefully drive home that for EVAR patients, you really need lifelong surveillance, and you have to accept the possibility of needing more interventions later on to manage that risk and address the less favorable late survival compared to open surgery.
And this wasn't just academic discussion, right? This data actually influenced healthcare policy. I remember hearing about NICE in the UK.
Absolutely. The National Institute for Health and Care Excellence, NICE, they provide guidance for the NHS, and they explicitly use this 15-year data to raise serious questions about the long-term cost-effectiveness of EVAR.
Because of the need for all that follow-up and potential reinterventions.
Precisely. When you factor in the cost and resources needed for potentially lifelong intensive surveillance, the economic argument for EVAR becomes less clear-cut compared to open repair, despite the higher upfront invasiveness of surgery.
Okay, so we've identified this long-term issue.
Yeah.
Late ruptures, higher aneurysm deaths, and the challenge of surveillance. What's being done about it? Are there solutions on the horizon?
Oh, definitely. There's a lot of work going on. One really interesting area is developing better ways to predict risk. Dynamic prognostic models.
Dynamic models, what does that mean?
It means instead of just looking at a single scan, you track the trajectory of the aneurysm sac size over time for each patient. How fast is it growing, or is it stable? The idea is to use these growth patterns to identify much earlier who's heading towards trouble and might need a preventative reintervention.
Right, being proactive based on individual trends. That sounds smart.
Yeah, and related to that is using computer modeling something called discrete event simulation, or DES.
Okay.
This can help figure out if the current one-size-fits-all annual CT scan approach is really optimal. Maybe, just maybe, a large chunk of EVAR patients whose sacs are completely stable year after year are actually at very low risk.
So you could tailor the follow-up. Less intensive for low risk, more for high risk.
That's the hope. It could make the whole process more efficient, less burdensome for patients, and more cost-effective overall.
That makes sense. What about making the surveillance itself easier, given that dismal 10% follow-up rate?
Yes, this is where some really cool patient-focused ideas are emerging. One concept is using a simple, portable Doppler ultrasound device. perhaps even one that connects to a mobile phone.
An ultrasound on your phone?
Well, connected to it, the idea is maybe patients themselves or their local GP could do an annual check of the sac diameter right there in the community. No need for a big hospital visit or a CT scan every time for everyone.
That would be a game changer for access and convenience.
Potentially, yes. It could empower patients, make it easier to stick to the schedule, and reduce the burden on specialist centers. And it's not just theoretical.
Ah.
MICE is actually aware of a big ongoing UK study called DETECT. It's being coordinated by Imperial College London, involving lots of centers. And it's specifically testing community-based ultrasound surveillance for checking EVAR sac expansion.
So real-world testing of this approach.
Exactly. The hope is that this kind of community ultrasound strategy could significantly improve the cost-effectiveness equation for EVAR while keeping patients safe.
So where does that leave things now? Has NICE's, pulled the plug on EVAR funding based on the EVAR Trial 1 results?
Not entirely, no. It's more nuanced. Funding for EVAR is definitely more restricted now, more carefully considered. But it hasn't been completely withdrawn. They're essentially watching the space.
Waiting to see how these surveillance strategies pan out.
Right. Waiting for results from studies like DETECT and seeing if these innovations can effectively mitigate those long-term risks and costs associated with EVAR. It's an evolving picture.
Okay, let's try and pull this all together. If you had to give the main takeaway from this deep dive into 15 years of EVAR versus open repair.
I think the crucial point is this trade-off. EVAR clearly wins in the short-term, lower immediate risk, less invasive procedure. But open surgery seems to offer better durability and survival in the very long run.
And that long-run difference is driven mainly by that higher risk of late aneurysm-related death in the EVAR group.
Primarily, yes, due to those secondary sac ruptures years down the line.
Which just hammers home the point about surveillance, doesn't it?
Absolutely critical. If you have EVAR, that lifelong commitment to monitoring and the possibility of needing more procedures, it's just part of the package. You can't forget about it.
But it's encouraging that work is happening to make that surveillance smarter, maybe easier, perhaps using community ultrasound or better risk prediction.
Definitely. There's real hope that we can find better ways to manage that long-term risk more effectively and efficiently.
So thinking about all this, the long-term data, the challenges, the potential new solutions, it really leaves you wondering, doesn't it? How is this ongoing story going to shape the conversations between doctors and patients deciding between EVAR and open surgery for AAA in the future? It feels like the final chapter hasn't quite been written yet.